Very good morning, people. I'm once again to present a case in front of you. I'll begin with the opening slide. What we can see right now is a very common fable which we have studied back in our nursery classes, right? So, the topic of my presentation is a wolf in a sheep's clothing. I am Dr. Joydeep Shah, a postgraduate resident from second year, Department of Respiratory Medicine, NRS Medical College and Hospital. So, we'll move forward with the case. Case details my patient J. Moody, a male from his late 20s, Hindu by religion, a construction site worker by occupation, hailing from Purulia, presented with the chief complaints of cough with expectoration since the last 1 year, progressively increasing shortness of breath on exertion since the last 6 months, and on and off episodes of fever for the same duration of time, that is 6 months. Moving on with the history of present illness, he was apparently well 1 year back when he started developing an episode of cough, which was initially dry in nature, later progressed to being productive, which was mucoid in nature then, not associated with any positional or seasonal variation. This was also associated with shortness of breath on exertion since the last 6 months, which had initially been MMRC grade 1 and now had been progressed to a rate of MMRC grade 3. And this was not associated with any diurnal or positional variation. Accompanying that, there was on and off episodes of low-grade fever, transitory relieved with over-the-counter antipyretics, only to recur again over a period of 6 months. Apart from that, he had no complaints of hemoptysis, epistaxis, or chest pain, or any other complaints as such. So the past history, he is a known case of pulmonary tuberculosis, but this was not clinically or this was not microbiologically confirmed. This was rather clinically diagnosed as a case. He had no known comorbidities and one previous history of hospital admission for the same complaints. Personal and social history: he is married for last 4 years and has one child. A construction site worker by profession, by as was already told, and his smoker. Bowel and bladder habits are within normal limits. Sleep and appetite are absolutely normal. Family history: no history of any similar illnesses in any of the family members or first degree relatives. Drug and exposure history: he used to take tablet paracetamol for the intermittent fevers, and apart from that, he had been on ATD since 3rd of November 2025 and continuously taking that since last few days. He is about to complete his course right now. And apart from that, no history of allergy to any substance or food, and didn't have any contact with any animals, pets, or birds, or fed them at all. On general survey, the patient is alert, conscious, and cooperative, oriented to time, place, and person. Decubitus of choice was propped up. He had average build and nutrition. Pallor was absent. Extra cyanosis edema were absent. Clubbing was absent. Neck veins were not engorged. Neck glands, no palpable lymph nodes were noted. A thyroid swelling was present. Temperature was febrile. Saturation was 91% in room air. And BMI was 23.78 kg per meter square. Blood pressure 126 by 72, pretty normal. Respiratory rate was 18 per minute, regular abdominal thoracic type of breathing with use of accessory muscles present. An intercostal suction was noted again. Pulse was 82 4 beats per minute and absolutely normal regarding the other parameters. Moving on with the examination of the respiratory system. On upper respiratory tract examination, basically the nose and nasal septum, tenderness over maxilla or not, gums, teeth or palate, pharyngeal wall, everything was normal. Moving on with the examination of the lower respiratory tract, which is further headed by the four classical headings. On inspection, shape of the chest appears to be normal without any skeletal deformity. Movement of the chest bilaterally symmetrical. Apical impulse was noted in the left fifth intercostal space, half-inch medial to mid-clavicular line. Trachea appears to be in the midline, and accessory muscles of respiration were working. Skin over back and front of the chest appears to be normal. No visible prominence, scar mark, rashes or lump were noted. Basically, on inspection, no abnormality was found in the patient. So we moved on to the palpation. Surface temperature was not raised, no tenderness present. Chest movement was bilaterally symmetrical with respiration. The only finding was, or rather in the palpation also, no abnormality was noted. Pretty good till now. On percussion, here we find the abnormalities like while percussing in the anteriorly along the 4th to 6th intercostal space, dull note was noted. On the laterally along 4th to 8th intercostal space, again dull note was noted. In the back along the interscapular and infrascapular region, again dull note was percussed. Moving on with auscultation. Normal vesicular breath sounds were heard basically in the upper part of the respiratory in the bilateral lung field. And along the axillary, infraaxillary, interscapular, and infrascapular, the vesicular breath sounds were pretty much reduced. But apart from that, there was coarse crepitations noted along the entire region. On examination of the other system, cardiovascular, GI, nervous, musculoskeletal, and lymphoreticular, everything was normal. No abnormality was noted. So I move on to the summary of the case or what we have seen so far. So my patient was a 20 male in his late 20s. He presented with the complaints of cough with mucus expectoration for the last 1 year, shortness of breath progressively increasing for 6 months, on and episodes of fever for last 6 months. No history of hemoptysis, chest pain, these was noted. On past and personal history, he is a known case of pulmonary tuberculosis which was clinically diagnosed because previously he had visited many hospitals and people were not able to treat his shortness of breath, fever or expectoration. So they had to start empirically ETD thinking that it might be a hidden TB. He had no comorbidities. He was a construction site worker by occupation, no history of exposure to fumes or animals or birds, and no known allergy to any medications or food. Apart from that, on general survey, saturation was 91% in room air. Accessory muscles of respiration were working. And on respiratory system examination, dull percussion note over bilateral lower intercostal spaces and coarse crepitations with reduced vesicular breath sounds along the lower lung fields. So I'll move on with the routine investigations. Accordingly, what we had progressed in the department. This was the initial blood investigation. The routine CBC which we sent. He had a normal hemoglobin level. Apart from that, the total leukocyte count was pretty normal, and it was in the normal differentials also. There was no like neutrophilic predominance or very high lymphocyte predominance. Platelets, LFT, RFT, proteins, all were normal. So no abnormality was noted from this aspect. Now we move on with the other investigation. Like the triple serology, the patient had absolutely non-reactive all the three HIV, HCV, HBsAg. INR was normal. CRP was mildly raised, which might indicate somewhat underlying infection. HbA1c was 5.7, pretty normal. Urine REMA within normal limits. Sputum CBNAT and GSCSFS, again no growth or pathogenic organism detected. Procal was within normal limits. So far till we have what we have seen so far is no clues or any hints we are getting at the diagnosis of the patient. So we have to move for the other investigations. This was the digital chest X-ray of the patient on the day of admission, right? So what we said is a X-ray showing a trachea in the midline with inhomogeneous and ill-defined patchy areas of peripheral fluffy opacities, right? We see somewhat in the right peripheral region, somewhat in the left, but we see the more of the maximum of the opacities are basically in the right, and there is a gradient which we can see. It is a basal predominant opacity, and there is obscuration of the bilateral sepia angles, and right head border cannot be straight. Might be due to a bit of rotation, but it is not pretty much evident right now at this moment. And the consolidation in the right middle zone can show air bronchoscopy, right? So we are still thinking in the lines of a consolidation, a pneumonia. The differential diagnosis from what we have in hand so far based on the history, the routine investigations and the X-ray can be division into it can be a pneumonia which can be due to a atypical one or not the proper antibiotic coverage had been administered, could be underlying malignancy as well, can be organizing pneumonia as well based on the radiology of the patient. It can be a chronic eosinophilic pneumonia, right? Like the typical X-ray which we saw in the previous slide showed the bat opposite of bat wing appearance, what we see in pulmonary edema. Can be a case of pneumoconiosis as well because the patient had a history of being working in a construction site. Apart from that, last but not the least, it can also be vasculitis, which can present in the OP pattern, right? So this was the chest X-ray of the patient over a period of 1 year from what when he started having the symptoms, right? So what we see in the X-ray is 1 year back, the disease, which was initial in its stage, showed a unilateral evidence, right? He had basically extensive consolidation in the in the left middle to lower zone, and somewhat air diaphragm can be noted. Moving forward in the timeline, the patient developed the consolidations in the bilateral lung field. Again, left is predominant, but in the right, it has started to develop by the month of October. And by the time the patient presented to us, it had a bilateral involvement with not a homogeneous appearance, but rather inhomogeneous looking fluffy opacities. And it was basically located in the peripheral regions of the lung, right? And over the period of 1 year, he had been admitted in a previous hospital, received antibiotics. He's still not recovering, shortness of breath progressive, expectoration progressing, fever still not resolving. The doctors had to administer ETD because of the non-resolving fever. Still no response yet. So what we are dealing with so far, we still have no idea. This was the CT scan of the patient in the month of February of 2026, done in a hospital outside, which basically shows a dense consolidation, right? The both parenchyma and the mediastinal cuts show the same. There somewhat nodules can be seen. There is a dense consolidation in the basal regions. No effusion is noted so far. Air monochrome can be noted. So dense alveolar filling opacity is what we are dealing with right now. So this was the CT scan of the patient in our department. We'll move with the mediastinal cut first. We are beginning from the up. Consolidation beginning in the left, gradually progressing down. Some nodules, again consolidation, air alveolar filling opacity, right? A dense consolidation which we can see. No effusion so far. It is pretty much same. Rather, a cavity formation can be seen in the left lower zone. Okay, we see air fluid level. Yeah, there is the air fluid level, right? So dense consolidation, and this one is the parenchymal cut of the patient. GGOs, dense consolidation beginning from left upper lobe, moving downwards bilaterally, consolidation. Nodules can be seen, gradually progressive airway. No effusion yet, but still dense alveolar filling opacities. We are still in a line of consolidation. And the cavity again, once again, left lower lobe, wall cannot be identified yet, but air fluid level can be seen, right? So we're dealing with a hidden abscess or consolidation which actually underwent necrosis. So something like that. This was the still images of the CT of the video I showed in the previous slide. So what I showed in the previous is what is being shown in here also. A dense alveolar opacity, likely consolidation, air bronchium noted, somewhat nodules in the parenchymal side, a cavity in the lower lobe. So still thinking in the line of a pneumonia, right? A pneumonia might be atypical one, which is not responding to antibiotics, and in leading to its complication, there is a formation of a abscess or a necrotizing cavity. So that's what we are dealing with so far. So moving on with the same, the baseline workup was done for like a 2D echo was performed. There's no abnormality was noted, right? Sometimes based on the X-ray, we can find that the patient might have pulmonary edema or not, a cardiac failure, but not in this case. The echo was absolutely normal. The USG whole abdomen again, absolutely normal. No clues so far. So thereafter, we begin what we do. Pulmonologists are we best at. We underwent with a fiber optic bronchoscopy, right? These were the images, initial ones, and the secretions were serous in nature while we were taking the ball, and it was seen coming out from the entire tracheoventral tree, right? So no segment or lobe was